regardless it is myopia or hypermetropia. Whenever we go to high numbers, I will tell you the cutoff values for myopia and hypermetropia. It is a relatively thin cornea, less than 500. But the shape itself is, you feel discomfort with this shape. So although it is just few things, but you don't feel you are happy. Look at this. The slope comes down, but after 6 millimeters. So that's good, no problem. The average borderline, as you see, that's why it is in yellow. So a couple of parameters which are borderline. Here is the holiday report. The central 5 millimeter zone. All numbers are normal in the best pictorial ellipsoid. And this is for the same patient. This is the epithelial thickness map. There is no focal thinning. So you can say it is fine. The cornea is fine. This hotspot is not associated with thinning in the epithelium, focal thinning of
the difference.
epithelium.
What about the difference between the sphere and the pier points in the epithelial mapping?
The epithelial mapping, which 2 points? This one is 55, this one is 52.
Yeah, the central part.
Central part, 53, 52.
Yeah.
Okay, and this is the left eye, you see? It is against the rule astigmatism, skewing, although it is insignificant, but you feel the eye itself is not comfortable. So for such a case, look, the slope is also normal. The holiday report is normal. There is no focal thinning. It is 49 above the superior, 53 in the inferior, so there is no focal thinning. Okay, so what do you think, Dr. Tarek? Now, we can say it is only thin cornea, but relatively thin cornea. So do you do LASIK, for example, for this patient?
I have to go for biomechanics.
Let's assume the biomechanics are okay.
It depends on the error for the patient.
-3.
If the biomechanics is fine and other eye is the same, I would think of PRK for this.
PRK is better, yes.
So you can go for PR.
Yes, more safe.
And if the biomechanics borderline,
Follow up,
better go for
follow up. Yes.
Very good. Okay, fantastic. So this is for case number 2. We come to case number 3. Very interesting case. Very steep, as you see. But the difference is 1.7. You see, if you superior and inferior, it's 1.7. But no elevation on the posterior, no elevation on the superior. And it is 479 microns. Okay? Now, holiday report, the 5 millimeter central part, it is normal. And as you see, the slope is consistent, and then after, almost at 8 millimeters, goes down, which is insignificant, and the BAD is fine. So, look at this. The staging, it says that let's see this patient coming for LASIK procedure. Of course, I'm not mentioning any refractive error because this is just can apply for any refractive error. All cases that I'm going to present can apply for any refractive error. So this is the first case. Now, as you see here, the KM is below 47.2, and pentagram should be less than 48, sorry. And for the first location, this is above 500. There is symmetry. This is 46.8, this is 46.9, so no difference, almost We can see the thinnest location because this is specific sphere, 8 millimeter. Here is +5, here is +8. So it is below the cutoff values, which is normal. The shape of the pachymetry map is concentric, so it seems normal eye. There is something in the BAD on the anterior surface. This is anterior, but it feels suspicious because it's in the yellow zone. Regarding the slope here, it looks normal, and the average is below 1.2. So all aspects are good, except this one, EF. It is abnormal. Now, this is the holiday report. Why I see the holiday report? Because I want to check the best fit toric ellipsoid as well at 8 millimeter. I look at any number within the central 5 millimeter zone, all the zone. Not only thinnest location as the best fit sphere. In best fit sphere, we look at the number corresponding to the thinnest location. But here, any number within the 5 millimeter zone. It should be less than +12 for the anterior and +15 for the posterior. We can see it is normal. Now, if I'm going to do lens-based refractive surgery, what do we what we must see in this? Do you remember who attended the last session? In the holiday report, there is another parameter that we look for when we want to do lens-based refractive surgery or cataract. What is it?
New cut value.
The coordinate. Coordinate. The coordinate here is similar to angle kappa. It is more accurate than angle kappa, and we have to look at it. Okay? Now, this is the left eye of the patient. So, steepness, as you see here, the steepness, yeah, I can move this. When we look for the first file, we can see that it is steep. It looks like steep, but steepness should follow some rules. Not every steep cornea is abnormal. So as you see, this is symmetric, as you remember for the right eye as well. And there is no skewing in the center, no skewed right
Regular.
axis. And all other parameters are good. So, and this is for the BAD. It looks very normal. And this is for the holiday report. Now look at the coordinate. It's showing in yellow because it is above 0.42. But because here it is laser based, by the way, we take the coordinate as well into consideration in laser based if it is hyperopic treatment. Hyperopic treatment or high astigmatism, we have to consider the coordinate for decentering the ablation profile to be centered with a visual axis.
Yes.
So the decision in this case is straightforward. Everything is fine. We can do surface ablation or LASIK or SMILE. Of course, in my cases, I'm not discussing which one is better. That's why I'm not giving numbers. It is just based on the tomography to do or not to do. So let's go for case number 2. So what do you think about this? Dr. Hassan, what do you see here?
Screening. Symmetrical photo كمان.
There is
Posterior elevation.
and
في
for this
thinning.
thing, we have
Yes.
to look at the
Anterior elevation.
topographical astigmatism. If it is less than 1.5, we can ignore it. Okay, great. It is 0.6, so we can ignore it. Very good. And
So I learned a lot, and I think that every one of us is learning during this session, so thank you. Actually, when I sent this topic proposal, I thought it was a theoretical talk lesson, so I didn't know it was then fit into a practical course. So we have two options. I can do this part very quickly, and then move to two cases that I had discussed it yesterday when I realized it was a practical course. Or we can skip the part, the theoretical part, which is on the concept of flap relief versus flap PK with some literature's evidence base, and just go to the cases. What do you prefer? Maybe we can keep the mood and go to the cases. Okay. So this was all the theory about retreatment, what you have to pay attention when you retreat a patient. Just some take-home message. Now we have the possibility of studying the core in a better way because we have epithelial maps, we have this nice OCT integrated tomography, so you know how the flap is thick, how the residual stroma bed is thick. So you can make this as a guide for your judgment before thinking what to do. If you have to relift the flap, do PRK, you have sufficient enough residual stroma bed. If your flap is regular or irregular, you want to relift it. So you have all these kind of systems now. And so actually you can do, if you want to retreat a LASIK, both options, flap, relift. Of course, relifting the flap is easier if you're doing it in the first month after surgery, but there have been case reports where you can relift the flap even for after years. So not stopping now for this theory, just two cases that I managed to find in my laptop yesterday night, and I would like your comments. So this was a case with the Visomax. This is the 800, in which this patient was a very young patient, like 25. She was a wedding planner, very sophisticated lady, and she refused at all PRK, and she wanted a LASIK because of the pain, because of her thoughts. Refraction was like -4, something like that. And so this is what happened. So you see the preparation. Sorry, I didn't have the time to cut the movie, but okay. The docking, perfect. And then laser cut starts here, and then everything is done. The cut is complete, well centered. First eye done. Then we move to the second eye, which is in the same movie. You change the patient interface, you prepare the eye, you put another drop of anesthetic, you do your centration. I'm going quite fast. Okay, so this is real time. Then you do the docking, well centered, then you start, and the laser cut the flap. Now the side cut is done. So, perfect. You're happy with that? Yes. During this moment, I heard from the MEL 90 a sound that was poof, something like that. So the excimer laser broke. And in that moment, and I asked to the technician, what's happened? I said, let me try to solve. I said to the patient, look, we have to wait, sorry. And we waited 5 minutes. Then I saw the face of the technician becoming darker and darker. And then I said to the lady, maybe it's better if you go out and we will solve the problem and let you in again. So she was like this, with two flaps nicely cut, with all these initial gas bubbles in the interface, but without excimer. And so I said to the patient that we have a problem. So what would you have done? You cannot do any kind, because the excimer was broken, so nothing that you can do on the same day. Then I realized that they talked with Germany. It was a hardware problem, like a pump or something, and they need, a piece that had to be shipped from Germany. So approximately 10 days. Okay. So what would you have told to that lady? Saying that, okay, there are variable options. You can call a friend if it's in the clinic and they say, can you lift the flap and do the procedure? But it was not the case. Any comment?
What I know about lifting the flap that can still be lifted even within maybe 1 week or even 10 days. Of course, the more time it will be more difficult, especially to recognize the side cup, but you can still find them and you can still lift the flap within maybe 10 days.
Okay, so thanks for the comment.
Well, from my experience with Visomax specifically, and from FS200, because I'm doing what I call it bioptics, so I do the flaps, and then I do, for example, ICL, and then get the patient in 2 weeks and do the laser for the astigmatism. I'm lifting the flap and put it back without doing laser. So I make sure that the flap is dissected, and because sometimes, especially with Visomax, it's very difficult to lift the flap after a while.
Okay, so the two options were don't touch the eye and try to relift a flap after 10 days, or convince the patient to do a PRK after 10 days, or lift the flap immediately and put it back, and then do a LASIK in 10 days. Actually, the decision was taken according to the fact that she completely refused PRK. So I had to decide whether to lift the flap or not at the moment. And then I decided not to lift because of safety reasons. She had to go back to Rome, bilateral, so the vision was and the risk for infection, you never know. And that's why I said, okay, we don't do nothing. And in 10 days, we try to do exactly what Dr. Sinjak said. So trying to lift the flap. And actually, can I? Okay. This was just to show you what you had immediately after surgery. So a flap creation without separation. You still see after a few hours exactly the nice work of the femtosecond laser. The map didn't change. This was before surgery. This was after flap creation without separation. So absolutely seems untouched. This was 10 days later. So at the OCT, you don't recognize almost nothing. And also the slit lamp, you don't see almost nothing. And you see that the topography is the same. So it's very difficult to find the flap. The problem is that you have to find the edge. Once you find the edge, as you said, then you can try to go in. And even if it was not separated, you can see what happened here. So you try to see where the flap edge is, because it's not visible. And sometimes it is exactly where you think it is. Sometimes you think it is in some place and you don't find. But once you find the flap, you can see it here. So if you remove the epithelium, it's easier. But sometimes also removing the epithelium doesn't help you if you're in the wrong place.
It's risky.
Yes, it's risky because of the epithelial growth. Yes. So here I found the flap edge. And once you find here, then you can follow it easily. And in the other eyes, it was easier in the left eye. So you see in the left eye, it was identified immediately. And here we had to play a little bit. We removed the epithelium. Interestingly, we didn't have epithelium growth in the right eye. We had epithelium growth in the left eye. Yes?
May I comment on?
Yes.
On this? Let's say in the beginning of the search about the edge, we can put a drop of Bradford.
A drop off?
Bradford.
Okay.
Bradford. Yeah, prednisolone
Yes.
suspension in order to cover the cornea, and then I will do some kind of manipulation, pressing at the periphery of the cornea, and it will show you like a step. There is a step. It will be very subtle, but you can recognize this step that the cut is there. So you can go from that.
And this is visible also in the microscope of the Bismarck, which is not an excellent surgical microscope.
Yeah.
Okay, great suggestion. So finally, so it was identified in both eyes, and I will go. And you see that you can open quite easily, even if it was cut 10 days before, here, and also here. So once you find the interface, even if it was untouched and not separated and cut 10 days before, it means that the femtosecond laser is not true that if you leave it as it is, it's nothing done. So this is another take-home message that you can leave from these cases. And then the LASIK was done excellently. So this is before and after. Actually, before this topography, at 3 weeks, we had to do flap relief for an epithelial growth, but that occurred in the left eye, the one that was without problem in the epithelial separation. So any comment on that case?
Yeah, I have a comment. After
having this experience right now, and if God forbid you have this similar experience with your eczema machine, when you do exactly the same, or you will lift the flap and put it in?
So the question is, can you?
If you have the similar situation,
Okay.
exactly like what you have after having the experience with difficulty in finding
Yes.
the edge of the flap and have to remove the epithelium,
Yes.
would you lift the flap and put it back, or you just wait for 10 days and try to manipulate as you wish?
I think that having gained this experience, probably I would not open the flap because I don't like to have the patient. It's a question of also, you have to discuss this with the patient, because you have to tell her that, or him, that you open the flap, you did some kind of, let's say, invasivity in the eye with nothing done. So we both have to accept this with some risk, even if they are very small, or for infection, flap dislocation, whatsoever. If they accept, or she accepts, then it's fine, because then it's easier to do everything. But if you're not confident that the patient perfectly understands, it's better to say we did almost nothing. So your eye was not operated, it was just some gas bubble inside, and then we will see what to do later. This is what I did. So probably I'm still more confident with what I did, even though you can have problem with epithelium. So maybe I will take this suggestion to easily find the edge. But I think both are fine. Okay, if there are no other questions, I can go to another case. This is a smile, not a lazy case. And actually, this was a case performed by a novice young surgeon, and he had a problem. You can see the problem here. This is the video. So you find the anterior channel of the smile on the right side. Then you find the posterior surface channel on the left side. And then you enter with your preferred instrument to separate the anterior surface. You see that it was quite difficult eye, conjunctival chemosis, not very easy. Also, the surgeon was not very confident, and so not easy surgery, I guess. Some tissue resistances. So the anterior was, and posterior in his mind were dissected, but there is no lenticle to grasp. So he said, okay, let me try to see where the posterior interface is. And then some bleeding for the peripheral vessel, because it was a contact lens where then entering to the interface, and this reduced visibility. And then if you start to grasp the edge of the side cap, the cap could have carter. And then he aborted the procedure with no lenticle extracted. So what happened in your opinion, and what to do?
I think he dissected the anterior surface only.
Okay.
When it reaches it, or maybe he started with the posterior, because I can have a little focus from the video.
Okay, actually, so I was in a meeting, and they said me this happened, and they sent me. I was actually in San Marino, and also my colleague Professor Mastro Pasqua was away. So the young doctor sent us this image. So actually, this was taken a few minutes or 1 hour after the 10th surgery. So you see that there are very swollen cornea, like 1 millimeter, because of the manipulation. And you see that there is some hyperreflective line for the posterior surface of the lenticle. We looked carefully at this image in order to see whether it was a false plane, because then it's a nice one. But probably this was not a false plane, this was the posterior surface separated. And the anterior surface, which should be somehow probably here, not separated. So the best option is that it is always in the posterior surface without cutting, without dissecting the anterior surface plane. It is what we call lenticle stuck in the cup. And we said, okay, leave it as it is. And then I came back on Saturday morning. This is, okay, just the problem at the side cut that was a little bit stressed and tear apart. And this was topography, 930 microns thickness and very regular central topography. But this was probably due to the postoperative edema. This was what I found before going to the surgical theater 2 days after. So you still see that there is a separation of the posterior lenticle, and you see that there is some lines, hyperthyroid line indicating there is still intersurface separation. So I had to decide what to do. Try to challenge in finding this, let's say, anterior plane, or leave it as it is and do probably a recut or a PK or PRK in the future. What would you have done?
I would wait until the edema subsides completely. Then I would bring back the patient and try to find the anterior plane and dissect it, and then remove the lenticle because the posterior plane already dissected. So maybe waiting for about 1 week or 10 days, 2 weeks until the edema subsides and redo. Not redo the smile. So
Just try to
yes.
to complete the dissection.
Yes.
Okay. Any other comment?
Totally agree.
Okay. No other comments. Yes.
I have very small experience with smile, so I just thought of something. Could you do like the circle mode and elevate the flap and try to peel the lenticule from the backside of the flap?
Yes, this is a kind of.
This is only fancy thinking. I've never done that before.
Okay, we have no. I'm not a fan of this kind of option, that is the circle mode, because it has a lot of drawbacks and difficulties. And this is suggested to transform the smile into a flap-based procedure in case of enhancement. But if you have to, and also you have some, difficulties in doing that, centration whatsoever, thickness. If you're combining the difficulties then in having a lenticle that should be extracted without separation on the anterior surface stuck on the cup, then I think you can enter into a nightmare. So I didn't think about this. The problem was that this patient lived like 500 kilometers away. She had 3 kids. She was a mother, and she said, I would like to have something done today. I agreed that the edema was not completely subsided, but I also thought that the more you wait, you have to separate what was not separated. So let's see. And then I said, just go into the microscope and see what I find, and let's decide together to the patient if I can complete the procedure or not. And she agreed. And the topography improved from 900 to 700 thickness, which is better, but it's not important. And this is what I found. So, you see that you have a tear, but I'm sorry. What's wrong? I thought. Just in the more interesting part. Yes. So while you solve the problem, so the idea was to see intraoperatively if you can try to find the plane of the lenticle, of the anterior surface of the lenticle. The difficulties, this is what I try to do, is that when you have a very stable cup without edema in the tissue, yeah, then it's quite easy. But if you have this tear of the side incision, and then the tissue is like black, and it's also softer because of the edema, it's not so easy. So this is what I found. I tried to see if I could find a plane in the cup. But if you have a very solid cup, it's easier to go in the instrument. If this cup is floating somehow, it's more difficult. But we managed to find something.
How about going with a reverse scheme? So
Yes, this is another option. We didn't have. I'm very confident with this kind of blunt instrument, but it has some kind of an edge that helps you. So I think any surgeon use what is more confident in his hand. I don't use generally the CSP, so you see it was not so easy, but finally searching, we're looking for the edge, so we didn't find. You see how the incision was damaged? Okay, now from the side, I enter it into the right plane probably. Then you have to take risk. Am I in the right plane? It should be. Then when you're sure, only when you're sure, you cross the pupillary area. And then you can change your instrument. You can try to separate the anterior surface. And finally, if you get this, your lenticle should be there, and it's there, and you can extract the lenticle. Of course, you have then to pay attention that the lenticle is entire, so it's not damaged, and so you can understand it. It was completely roundish, and it was whole. And interestingly, that patient, then she healed quite well. At 2 weeks, the cornea was good, and also the vision was good, and also topography was good, and the minor damage to the side incision, you know, when you have this kind of tear, they can heal quite regularly without even using a stigmatist. So it was a good case, but very challenging. Thank you.
Stigmatic pattern, so I can have what I call it oval flap or elliptical flap. You can change the direction of the ovality of this flap according to the axis of the astigmatism, whether it's against the rule or with the rule. And you can see here the video showing the oval flap. You can see the slightly horizontal, and I change the location of the hinge according to the axis of the astigmatism. I started using this like 10 years ago, and now this is an oval flap, as you can see, and you can see this is after reposition of the flap. And what I'm doing right now is I'm using a wide hinge flap. The wide hinge flap, I even go for 5.5 millimeter. I believe this gives the flap more stability. You just do the wide hinge flap, as you can see here. This is my hinge, actually. Theoretically, you cut less nerve layers, nerve fibers, so theoretically you may end up with less dry eye. Lifting the flap is easy, and no problem with lifting the flap, and even with laser, because you have seen everything on the screen that the laser will hit on the stroma. The thing is, this is a difficult case because you have some sort of bleeding, so you need more wash so the stroma is hydrated, the flap will hydrate, but putting back the flap is extremely easy because the wide hinge doesn't let you move from side to side, it gives you less striding. So I'm using the wide hinge flap for almost every case except for hyperops. As you can see here, even for myopia, not just for astigmatism, you can use the wide hinge flap. Okay, I'll go for some complications. We used to have this sort of complication when the laser head is going to be replaced, and sometimes you face sticky flaps like this one. What I'm doing, if you have a sticky flap like this, I'm trying to divide the resistance. So I start with dissecting the easily dissected areas, and then not to have the whole resistance with one movement. So I divert the flap afterwards, so I have this sticky area. This one, like we're discussing, if you have an OBL with Visomax, this is with FS200, not with Visomax, but I got this experience with both machines. So you just have one minimal resistance, and then you can dissect it bluntly with no sharp instruments, because sharp instruments, if you are not experienced like Dr. Noel, you may end up with making a buttonhole or cutting the flap. Another case, and I'll go to the go. This is the case of the famous suction loss. you start doing your laser surgery, the femtosecond step, and then the patient moved a little bit, so you stop. What will you do for this patient? We start with Dr. Mazin.
Yeah, because it did not cross the pupil. Yeah,
okay.
so for me, I usually wait maybe 1 hour. This will disappear and then I redo it. But maybe in this machine, I don't know about redoing the 1 hour, but I'm talking about VideoMax.
Okay.
I can redo very smoothly after 1 hour, very smoothly.
Dr. Hosni have an experience with all machines in the world, so with FS200, what's your experience with?
I would redock and redo the after like 1 hour, exactly like Dr. Mazin said. But my honest advice is get the Z8.
Okay.
Get the Z8.
Would you use the same cone?
This was it used to be the case with intralace. This was classic teaching because each cone has a different imprint than
The
the
same for
other.
FS200.
You can use the same cone if you have an extra cone that you'd like to use. You will not have two levels. This is something that never happens. Provided that you do not attempt to elevate this at all.
Of course, there's no side cuts even.
You'll have only one.
Dr. Nobel?
I would do the same. So redock. And so since we use the Visimax, you know that you have different pattern. So because it's circular. So if you have a stop of suction loss in the first phase, the pupil is always paired. So I would do a redocking in 1 hour.
Would you use any different configuration of the initial flap? Increase the flap diameter? Or?
Just to be sure, if you want to be on the same size, if you change some parameters, so if you can do a different thickness and a different size, it's better because, you know, with the Visimax, it's not easy to redock in the same place.
Exactly.
That's why if you enlarge the flap and you get the flap deeper, for example, you're sure you're not crossing the two lamellar dissection.
What I actually do is using the same flap thickness and a little bit wider flap. But I would change the canal placement because the canal is already open here. If you have this air bubble in the AC, how would you manage it? Have you experienced an air bubble in the AC, the VideoMax?
In the AC, never.
Source A.
With FS200, every 10 cases, you get one of those.
Not everything.
10 cases.
This was the old laser head, by the way.
Okay.
But now it's not that common. But I used to see it like 10 years ago, maybe. But now it's not anymore. But the problem is with the eye tracker. But nothing serious happened for this patient. This is the bottom.
So what do you do? Do you wait until it's closed, or do you go ahead and
I
fool the machine?
I try. It depends on the refraction. Actually, I try. If the eye tracker is okay, I would go and proceed. If the eye tracker is not working, if it's like -1, -2, so I can, and the patient is cooperative and he can look
So
straight.
you
at the-
disengage your eye tracker.
Exactly.
Okay.
But if it's an hyperope or have astigmatism, if I need to correct the cylinder and need to do some sort of cycle torsion control, I wait until the air bubbles are
Because
gone.
there is the small disc that you can actually fool the
Yeah, I
machine
know, I
with.
know.
Okay,
I did it before. Okay, thank you for coming. The femto laser is doing the foot construction here, and there's pulses and vasculace, and then we have a dissection. I know this case was intended for young colleagues, but you can see here that these gas bubbles are escaping from the canal here, and you can see the bubble escaping from here. And this is one of the advantages of the newer platforms of the femto laser, so you don't have trapped gas bubbles inside the flap. But sometimes you are facing stuff like this. This is what we call it OBL, or opaque bubble layer. The opaque bubble layer is because the canal is not formed. I will go for the floor, of course. What will you do for such a case if you have an opaque bubble layer like the one I showed? will you proceed to do the surgery? Will you face any resistance in lifting the flap? What do you think? Start with Dr. Noble.
Can you show me again the initial part of the movie? So you got this flap that was? So I see some OPM,
Yeah.
but I missed the main concept. What was the problem?
The canal is not open, so this is a flap with an open canal. This flap, the canal here is not open, so there is an OBL here.
Okay. So you think it is not open at all, or is just the OBL covering the canal?
The canal is not open, so there is an OBL in the
The OBL happened
interface.
because there's
The
no
interface.
venting from the canal.
Okay.
It's not venting.
Okay. Therefore, you need to probably try to reach the canal manually with a blade.
Mhm. The canal itself, with a blade.
Have you tried?
I will continue the video later on, but after having your opinion, Dr. Hosni, what will you do for this case?
This is a minor inconvenience. Go ahead and complete the case.
Mr. Mazin?
I mean, I'm always worried about clear bubble there. Okay, sorry.
Dr. Mazin?
No comment.
Hmm?
I have no comment.
Why? Would you lift the flap, or you repeat the procedure, or just continue?
Because of the OBN,
Yeah.
I use the Mario Max 800,
Mhm.
and it happens frequently.
Yeah.
I use the dissector for the smile
Mhm.
to dissect the areas for the OBL. So I never stop because of IBL. I usually lift, dissect, and dissect. I continue.
I chose this case because there is different platforms. If you are using the VisuMax, for example, it's very difficult complication. You can't lift the flap easily because the OBL covers the laser, so there is no dissection in this area. While if you are using FS200s in piece of cake, I don't consider it as a complication, and I can lift the flap easily and do my laser.
You had a certainty of a central buttonhole, but this was not lifted, so you didn't enter into this pocket dissection, so everything was stuck there. So I think that what you are doing now, so removing the epithelium and making a PRK on top could be probably the best option and the only option if you want to do something now, because if you abort the procedure without touching the cornea and then postpone kind of surgery, maybe if you don't have a scar, but generally if you don't touch what you get by the femtosecond laser, you don't get scar, then you can do a recut of the flap at a deeper layer if you have the sufficient amount of tissue. So my two preferred options would be if you need to do something immediately for several reasons, then do a PRK on top. But take a moment to see if you are treating a very even surface, because sometimes, because of the gas bubbles that can be trapped into the interface, then you have a bulge of the corneal surface when you do a PRK immediately. Once it happened to me that I had a suction loss when cutting a femtosecond laser flap before the ring cut. So for several reasons, this patient could not be postponed. We decided to wait some time. The flap was not open because it was not even totally cut, and do a PRK 1 hour later. When I did the de-epithelialization, I discovered that all these gas bubbles can be confluenced in one single bubble in the interface, and then you have to punch the interface to make it go out. Otherwise, you have a bulge, and the excimer laser will not cut on the surface perfectly. That's my opinion.
Okay, well, that's what I did, and then post-operatively, this is the pre and post-operative. So we can see that the right eye where I did, we have really very bad visual quality. Although the patient, I let him, because this was like 1 month post-operative, so still the cornea is remodeling, so I waited and I decided to follow the patient up, and this was the change in his refraction. So he ended up with the other eye, the femtosecond window right, he was seeing very well, but the one I changed it had a little bit of slender and the vision and the quality of vision improved. So I got away with this. So I did follow up, and the patient was happy actually.
Sorry, how about doing, for example, trans-PRK, but after 1 week, not the same session?
Yes, the patient disappeared, so he didn't come back. So the other thing, yes.
Just a quick comment. This is not a suggestion at all, and I do not.
So second laser. So this patient, not this one, this number 4 for the sake of time. So this patient, he came to me in April last year, and he is living in Germany, and then he wanted to come after a while when he is free, and he came to me at the end of the year. So the situation was like this. This is his patient. He is perfectly low mayo, very small amount of astigmatism. The thing that he has is wedding party in 2 weeks time. Okay, so I told him no, we cannot. Ali, I have to go to my wedding in 2 weeks time, and then immediately I'll go to Germany after my honeymoon. Okay, so this was the first stress factor. So we decided to do a femtosecond laser. You know, with the femtosecond laser, it's very, very, very rare to have a center. So I was, of course, trying to concentrate in doing. I'm working with Zimmer 8, and it's you have a screen, and then you can adjust the centration with the button. But what we did, we did this. This was the first eye, by the way, and I'll show you the video. And for my bad luck, at that day too, the video recording was not working, so we had to record this from the screen with a mobile. So I'll stop here and ask the panel. I have now a femtosecond flap for this patient, decentered temporarily. I'm going to stop now and ask what to do. If I elevate this flap, then I'll have. If this decentration was nasal, you know, because of the nasal shift of the pupil, I could do it. But this flap, I had to think at that time, and this patient is very, he's an engineer, and he needs very good vision post-operatively. Then I decided at this moment to stop and abort doing anything in this eye, and let the patient come in 2-3 weeks and do another session of 20 seconds. I did the left eye, it went all right, and then we went to do the exam. So after doing this, I had to tell the patient, discuss with the patient, because he has a limited time, and he has to travel. So we thought that, again, I would do him a trans-epithelial PRK, because the femtosecond is actually does not cut. It is displaced tissue or separate tissue. So that's what I discussed with the patient. I discussed the post-operative, and he, of course, he approved, and then that's what I did. I did him trans-epithelium PRK, and actually he went very well.
Yeah, I would have postponed the case to the end of the list, same day, and redo the cut.
Another hinge, another superior hinge, and
yeah, maybe another hinge, larger, deeper, a little bit, maybe 20 microns deeper should be, because the standard deviation of the cut is 18 microns before standard deviation. So 20 microns more, larger, and we can go for this same day.
yeah. Professor Noble, what would you do in such a?
Can I ask about, because for this, what was the refraction? Was it minus or hyper?
Minus.
Minus. Okay. So I don't agree with the comment, because it depends on the platform that you have. For example, we use the Bismax for Zeiss, and to do what it suggests. So redock after 1 hour, do a larger flap, and you want to be sure that the inch is exactly where you want to be. It's not that easy, because if you have cross section of the two side cuts, then it can be a little bit challenging. So my idea was to abort the procedure and do a transfer K later.
Dr. Hassan.
I think I would go for the same. Was this a one-step docking or a two-step docking?
No, I think it's 2 steps.
A two-step docking. Was it the 9.5 cone or the 10 cone? 10 millimeter cone?
I can't remember the cone, but yeah, this was very strange. This was first time for me to have this.
Because the reason for me asking these questions, because after you do the docking, you take a look at the screen.
Yes.
And it was not decentered on the screen?
It was decentered, and I tell the assistant just recenter it, and because of the suction, it takes some a little bit time, so I didn't want to wait a little bit. So okay, they said okay. So this was my mistake, and the assistant.
Because the thing is, if you find it very much decentered on the screen, we should disengage and then use another cone, even if it's a bigger cone.
You're right.
I think if we do another flap, it can end up, with the Olympic. I think I would go for surface ablation in this case, because sometimes it is tempting to decrease the optical zone of the treatment on the excimer machine and go ahead and do it, but then you will not get a good result as well.
How was the flap thickness here?
What?
The flap thickness.
No, it looks good. 120. This was a 120.
Reflection?
The flap thickness.
The intended flap thickness.
It's the usual. It's 110, I think.
If you are planning to go for another flap, you have to go at least 40 microns deeper to this flap and a bit larger flap, and I think it's going to be difficult in this case.
Yeah, but you wouldn't think of changing the hinge side, or as we used to do with the mechanical? No, the same, just the same, but a wider flap and a thicker. Yeah, thank you. Yeah, Dr. Tarek, because of same.
Thank you, Mustafa. Today I will try to show.
Yes. And the question is, did we get married?
I'll try to show some cases of femtosecond assisted LASIK, and I try to show.
Now this is a case of a patient having loss. Sorry? But they have a hash. Okay, this is a patient who had LASIK actually. And now they have +4. And we want to do fearless extraction. The patient is 40, for example. So, as you see, this movement, S shape, should notify us about the cornea has been done something to it. And as you see, the cornea mu is 0.21. I'm repeating the same parameters just to keep them in mind for cataract cases and clear lens extractions. The best two maps to discover if the patient had previous corneal surgery or not, previous LASIK or PRK or SMILE, are the relative pachymetry map, because it shows us the pattern, and accordingly we can know whether it is post-myopic or post-hyperopic. And this is not only for fancy that you have done something. No, it is for the biometric, because the machine will ask you, the patient had previous LASIK? Yes, it was myopic or hyperopic. Accordingly, it will choose the best formula for you. So you have to know by this. The relative pachymetry map will show you this pattern in the center if it is post-myopic, which means that the center was ablated. So all values in the center are negative. And the tangential curvature map anterior, it shows you the contour, and even you can measure the efficient optical zone that you get after the operation. For example, if you plan for 6.5, doesn't mean that you are going to get 6.5 after the operation. After 3 months, if you do the topography, you may find it 5.5. That's why do not manipulate with the optical zone in order to gain more correction. Optical zone is something holy. We cannot manipulate it. So, As you see from this pattern, it is post-myotic because the center is flat. Okay, so now, as you see, the spherical aberration with the pentacam is 0.3. Okay? Is 0.3. While in Cyrus, it is 0.5. Same patient. And I noticed this. Many patients I do comparison, I find that the Cyrus gives 0.2 more, either the RMS and in individual as well. So 20 minutes finished? So in such case, what do you put a lens? Let's assume that the patient doesn't have astigmatism. What lens do you put? And as you see, it is positive spherical aberration.
H.
And the patient would like to have depth of focus after the operation. Would like to maintain the depth of focus. And we know that the spherical aberration gives, even the positive, will give some depth of focus. So either, if you neutralize it by negative spherical aberration lenses that are available, you will lose this effect. Maybe you will get very sharp and good quality of vision, but you will lose that. So what do you put? Dr. Nabil?
The eye-hands, for example, it has a bit of depth of focus, although it has a negative spherical aberration, but it adds to the depth of focus, it increases the depth of focus. And there are other EDOF lenses that are very tolerant, although they have negative spherical aberrations, but the other part that compensates for that increases the depth of focus would compensate for this. Like the Lentis Comfort, and even I have some experience with the Look Smart. Very, very good results in these cases. Very tolerant.
What is it?
Bosch and Lomb, Look
Yeah,
Smart.
Look Smart. It is enhanced monofocal?
Yeah, it is EDOF, yes.
It is EDOF.
It is EDOF.
Spherical, negative spherical aberration.
Yes, and it works on the concept of combination of spherical aberrations, fourth and sixth order, opposite sides. It gives a depth of focus, and it's a very tolerant lens in these cases. The Lentis Comfort is a lens that works on, like it has like a segment for near vision with a very smooth transition zone. It's EDOF as well, and it is a very, very tolerant lens. No problem absolutely in post-operative, post-LASIK patients. I have a very big experience with this lens specifically and with the Look Smart. And actually, in both cases, the results are really good.
Fantastic. Thank you for sharing your experience.
A easier and safe lens, totally the eye mask.
Yeah. How about using monofocal with zero spherical aberration to keep the same spherical aberration?
I have a comment. I was just going to tell you this.
Yes.
Now, positive spherical aberration and negative spherical aberration do not necessarily increase the depth of focus. There was a landmark study done, I think in Cleveland, that actually it was an optical bench study, and they showed clearly that spherical aberration plus or minus 0.2 is the sweet spot that gives you a very good depth of focus. And this was coherent with our clinical experience. And when we started using the negative spherical aberration lenses back in the day, from the days of Technis 1 when we started, we had patients that had better depth of focus than the patients that were implanted with normal lenses, in spite of that the previous patients that planted with normal lenses had more spherical aberration. So it's not the amount of spherical aberration, it's the sweet spot of the spherical aberration. So I think keeping the spherical aberration, the neighborhood of 0.2, whether plus or minus, gives the patient the depth of focus. I have just two questions for Dr. Nabil. Have you tried, is this true with the mini well as well?
I have no experience with that.
Okay, so and the Lentis, you're happy with the Lentis Comfort?
Lentis Comfort is amazing.
Will be unhappy if you put oh yes, no,
We can go.
oh yeah, you don't can.
Yes. Yes. So either we go for enhanced monofocal or EDOF. Super. So the aim of this case is to highlight the importance of studying the high order aberrations for patients going for clear lens extraction to know, and even cataract. what we are going to say about in my lecture applies for cataract for premium IOLs. It is just the same. The effect of the cornea on the lenses, either in clear lens extraction or cataract. Okay. Now, case number 2. This is MS39 for a patient. Now, this is pupil coordinate. According to Francisco in the CSO, he considers the pupil coordination are representative for angle kappa. So as if we are studying angle kappa. So the angle kappa here is 0.39, quite high. Usually it should be 0.2. All right, so we have a little bit high angle kappa. And here is the epithelial mapping. There is focal thinning, of course. And this is the axial. So it's obvious it is keratoconus case. This is keratoconus case. All right. And this is for the high order aberrations. In the CSO, either Cyrus or MS39, we cannot select. We cannot say we want only these 5 high order aberrations and then study the RMS. It gives us the total, okay? 6 orders until the order of 6. That's why the cutoff value for the RMS is considered higher, so 0.7 for the RMS in CSO. Okay, here it is above 0.7. And we have to know on the account of what? Is it on the account of spherical aberration or vertical coma? As you see, from the shape here, it is obviously common. Mainly it is common. Okay? The spherical aberration is 0.58, so it is almost normal. The comma is 0.93, and the trefoil, residual means trefoil, 0.86. So this patient is typical for keratoconus. Okay. So what's your decision for this patient? And this patient has some astigmatism. There is astigmatism, which is, we can say, 6 diopters of astigmatism based on the KM. Okay? So, and the best correct visual acuity for this patient is 0.8. So, and we want to do clear lens extraction for him. So, do we put toric versus non-toric? And do we put monofocal, enhanced monofocal, EDOF, trifocal? So, Dr. Tarek, what do you think?
Well, in case of it's a keratoconus, I don't like to have a multifocal cornea and multifocal lens, even EDOF. So I would implant a toric monofocal lens for this patient.
Toric monofocal lens.
I don't do any sort of lumbar relaxing incision or any sort of cutting of the cornea, because this is a weakening procedure for the cornea that will weaken the biomechanics, which is already weak for the sake of keratoconus.
Very good that you highlighted this point. Do you do cross-linking in advance? Maybe you were about to talk about this. Okay, Dr. Khaled.
These patients are never straightforward for a couple of reasons. The first thing is, if he has keratoconus, sometimes they are hyperprolate corneas with negative spherical elevation. The problem when you pop in a toric IOL, these toric IOLs are all the new fancy premium IOLs with a negative spherical elevation incorporated in the IOL. So this can augment the negative spherical elevation that's already found in the cornea, so you won't get a very, very optimal result. But the good thing is that you don't have usually toric IOLs that correct 6 to 8 diopters of toricity. So you can put a toric IOL to just, to decrease the amount of astigmatism. In these patients, I would definitely advise the patient, especially if it is a relapse, if it is a refractive lens exchange that doesn't have a considerable cataract, I would definitely advise him to do a cross-linking first, and then to stabilize everything, because the keratoconus we know is a dynamic thing, and maybe the axis of toricity will change with time, and you pop in a toric IOL. The other thing is, even if you decide to do a cross-linking after surgery, the cross-linking itself changes the pattern and sometimes changes the axis of the coma and the axis of the manifest cylinder. So in this patient, I would stabilize the cornea first and then do a biometry later on. Our problem is we do not have toric IOLs that do not have negative spherical aberration. We don't have this. So we will not be able to put an SA or an NA, Acrisoft regular thing. So Mario has...
Can I make a comment? It is quite a very philosophical comment on this case. So I would ask, maybe I missed, what is the age of the patient? And if the cornea is stable or progressive? Because I think that if it is a young patient, let's say, that can have progression or not, I will never remove the lens for several reasons. If it is a, let's say, old patient, over 40 or 50, we know that the cornea is stable, then we can make different thoughts, I think.
So
Can I just a quick comment?
the patient is 35 and it has been stable over the last 5 years.
So the thing, I totally agree with what Mario said, but usually we encounter these patients in a slightly different scenario. These are patients that we did a DELC or a PK for, and then 5 years out they develop a cataract. And they're youngish and they have this sort of topography. Then we have all the right to go ahead and do a phaco for. But of course, if this is a youngster that like in his 20s and have a keratoconus, the last thing I would like to do is to do a clear lens extraction. These patients, he does have a decreased corneal rigidity and a decreased scleral rigidity. He can end up with a retinal detachment, and it will be, complexing the case much more than what it is right now. So I wouldn't do a lens extraction for this patient unless he has a considerable cataract. And from our experience, keratoconics do not develop a considerable cataract unless you do a penetrating keratoplasty or a deltoid.
Or if the patient had previous VKC and used
Oh,
steroids
yes.
for a long period of time.
Yeah.
So let's assume that this is the case.
Yeah.
And we want to remove the cataract. How about, there is a comment, please, yes.
I want to ask, the patient has a cataract? I thought the patient did not have a cataract. Is it a lensectomy?
It was like this, but we are just changing the scenarios just to discuss from different.
If it's not a cataract case, I would agree 100% with Dr. Hosni with first trust linking and wait for everything to be stabilized, and then why not an ICL, a direct ICL, in a young patient instead of changing instead of a lensectomy.
By the way, I'm presenting such cases because I see such malpractice. I see. Some doctors are removing the clearance. I am against this practice. I don't like clearance extraction. I don't do it unless there is high hypermetropia. Only high hypermetropia that cannot be treated. Yes, but unfortunately, we can see people till now. Surgeons are doing clearance extraction for everyone.
Yes.
So,
Can I say just a comment? I was invited in a debate defending or against clear lens extraction against one of our colleagues. So I thought this was a very easy task. I prepared the slides and the presentation. I thought it was a no-brainer and a very easy win. And